Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record. Also, please fill out the program evaluation, and as I always do, I'll ask you to give us any ideas that you might have in regards to future topics or future speakers. Actually, I think maybe this request came from the audience at a previous Grand Rounds presentation. Today, I have the pleasure of introducing Dr. Sarah Bancroft. Dr. Bancroft is board certified in family medicine, and more pertinent to today's discussion, she's also board certified in sports medicine. She's a member of the sports medicine department at McFarland, and also she's an official team physician for the Iowa State Cyclones. And she's kindly accepted our invitation today to provide us with some information regarding the pre-sport participation assessment. Please join me in welcoming Dr. Bancroft.
All right, well, good afternoon, and thank you guys for coming. I know it's absolutely beautiful out, so hopefully some people will be able to catch this on the video or webinar at their offices today, or maybe out enjoying a quick run or lunch outside. So we're going to talk today about pre-sport participation, and I think this is especially pertinent in the springtime when we're getting to see all of our athletes come back in and need to screen them in whether or not they're able to participate safely and any restrictions we have for them. So here we are. No disclosures, although a lot of people do ask me, aren't you married to another Dr. Bancroft? And yes, my husband is ENT here. So there are two of us. We've gotten called several times with the wrong operator phone call. So that's okay. It's no problem. We understand. So. Okay, so recently, a few weeks ago, I went to AMSSM. You can see my fantastic selfie on the left at Epcot, but most of what I did at AMSSM was go to conferences, and so we're going to be able to talk through quite a few of those things, and luckily at the conference, we had a specific set of lectures on pre-participation that was actually written by the co-editors of the new pre-participation guidelines that will be out this coming fall. So it was exciting for me to get a preview of that and be able to pass that along to you as well today. Also of note, we had some fantastic speakers. On the right side, you see a picture of Tyler Hamilton. He actually came as a keynote speaker, and he, as many of you would know, is the 2004 gold medalist, and unfortunately had that taken away from him after he did admit to doping and wrote a book called The Secret Race. And so a lot of really interesting lectures there and a lot of really well-known people that we got to listen to. All right, so objectives for today are to be able to effectively identify red flags for clearing an athlete for full participation, understand the locations and utilization of appropriate guidelines. There's a lot of guidelines out there for different things, and so hopefully we can at least give you a roadmap of where to look if you do have a red flag or something else that comes up that might need further evaluation with a pre-participation exam. And then also specifically understanding the categories for clearance in the adolescent population, because these can often be misconstrued and potentially mislabeled when you're filling out the examination. So as a background, there are two parts to our possible pre-participation. We're going to focus mostly today on this amazing book here, which I will caveat the new guidelines will be out this coming fall, so we'll be getting a brand new book, which will be the 5th edition of pre-participation. These guidelines are mostly published for the adolescent and collegiate population, but they do include younger athletes. I believe it's through about age 30 and endorsed by many of these different organizations. The ACSM actually has our adult guidelines, and those were updated in 2015. Those are endorsed by the Cardiology Association, Geriatrics, Public Health, Exercise Physiology, kind of all weighed in. And we will talk briefly through this discussion and where those guidelines are headed, but with adult pre-participation, it's much more focused on the cardiac risk, and then how do we make sure that they're safe to do the moderate exercise that's recommended every day and weight loss and things like that. Okay, so Dr. Bernhardt and Dr. Roberts, who are the co-editors of this edition of PPE, and also the next one, came and spoke to us at AMSSM. And really, one of the things that we take home is that the PPE actually doesn't necessarily effectively decrease morbidity or mortality. And that was shown in a study in 2004 in the Clinical Journal of Sports Medicine. And in general, we actually find that this is still the case. So why do we do it? Well, some people actually say we shouldn't do it. But unfortunately, or fortunately, this is a screening tool that we need to utilize, and it is required by many organizations, such as high schools, collegiate participation, and Special Olympics participation. And it's recommended that, in general, this pre-participation screening occurs at 6 weeks prior, but we do, unfortunately, have to rely on the parent to schedule this. And so when you're getting phone calls in, please do this early, because we need to have time to deal with the things we're going to talk about through the rest of the lecture in a timely manner so they can participate on the first day. So why do we do the PPE? The benefits are that we're actually assuming some legal risk, essentially. And this is why it's required by all of these larger governing bodies. And so we're actually creating a risk stratification with what we're doing. And so if you look at the different clearance, we basically have high risk, which would be not cleared for anything, for any reason, or maybe they're not cleared for a particular sport based on their deficit, or they are cleared for certain activities, which would be more moderate risk. And so that would be cleared with exceptions and follow-up needed. And then low risk would be considered really that they're cleared for all of these things. It's kind of like a pre-surgical clearance, right? So we're not necessarily saying that this athlete is not going to have a catastrophic event. We're really just saying we're risk stratifying that they are high, moderate, or low risk, and trying to quantify that for them when we fill out the clearance form. And so with this, the risk stratification can also change, right? Because the status of the athlete may change. It's different when you're first week post-op ACL and we're like, absolutely nothing. Or maybe they're just doing upper body stuff. Or in 3 months, they might be able to do some things, and then in 6 months, they might be cleared, right? So the risk stratification can change for these athletes. So what are we actually doing well? So here we've got a schematic here of what actually is accomplished well at the pre-participation. And you'll notice there's a lot of overlaps with your well or complete physical exam here. So we do a decent job when we do the PPE of disease screening, reviewing their medical history, growth and development, promoting wellness, and talking through things. And to the right here, we've got a diagram that's also within this book of a preteen screening. And that's actually something that we talked about specifically at AMSSM that is very important in making sure that you're not just doing the pre-participation physical and missing all of these well-adolescent guideline points while you're doing the pre-participation exam in this population. But what we don't do well, and we're going to talk through a little more today, is the things on the right side of this chart. We don't do a great job at preventing sudden cardiac death. And there are a lot of specific cases that I'm going to bring up even from my own experience, unfortunately. And we don't do a great job at promoting safe participation or doing anticipatory guidance on this. We do an okay job at injury assessment and prevention. And then meeting the liability standard of what these bodies, such as the high school associations, Olympics, collegiate level, Special Olympics, things like that, we do okay at. So there's a big debate about who should have the PPE and how should it be done. Should we have everybody do a PPE? Because all of our little kids, they go to gym class, right? And is that any different than somebody who's going out in an organized sporting event or a club event, that type of thing? And at what age should we do this? We had a vote, I guess you'll say, at our conference, and most people in the audience who are sports medicine specialists said that at age 6 would be a recommended time period, because that's when they're starting to enter into sports now, and starting school and PE classes. And should we require other groups? My opinion is yes, I think club sports should be required. Most of them do have their own governances that do say that they need PPEs. But I also see a lot of choir and band issues, so choir meaning that they might be doing show choir, or band, marching band. We see so many injuries in marching band. Liken it to an endurance sport, really, actually. So we see stress fractures. I see concussions from people getting hit with objects in marching band and show choir, and you wouldn't believe it, but it does happen. So should they be screened in those types of participation sports? How often should they be screened? So in Minnesota, they screen once every 3 years. In Iowa and most other states, they screen every year. Is there a frequency that's best? We don't really know. Can we squeeze this one into our well care? I think for the most part, yes, but it is extra stuff. It's extra forms. It's extra time. And if we're doing our well care, is it also enough anticipatory guidance on the sports side and vice versa? And how do we, can we separately bill for that? Is there a way to carve out a portion of our time? Do we need to just book extra time? It's always that right at the end of the visit, the mom's like, oh, wait. I have to give you this form. You have to sign this so that my kid can go play football next year. So then you kind of backtrack and say, well, is this the right time or is it not the right time? Should we be doing mass screening or should we be doing it in the office? This is a huge debate. Most commonly in lower socioeconomic locations, mass screening is preferred. Why? Because the kid's not going to get to participate if they don't get a physical. And we want them to participate. But the question then becomes, is the liability too high for the team doctor? Is it actually an adequate physical? Are we able to do all the anticipatory guidance that we want and be able to actively talk through the concerns that they have? This is really tricky. The location that I came from previously, we did a lot of these. To be truthful, it caused me a lot of anxiety internally because I'm listening to 50 to 60 kids in 4 hours. Am I in a quiet environment all the time to make sure their heart sounds are quiet and I can hear what there actually is going on there? It's just really, really tricky. But not everybody can afford or can come to the office. So that's a definite debate. And are there specific labs or tests that should be done? In review, the USPTF actually found that there was no good evidence-based medicine to screen for iron deficiency, sickle cell trait, or actually even EKGs in male basketball players who are highest risk that we're going to talk about in sudden cardiac death. They did find, however, that screening for depression and anxiety was found to be beneficial and helpful during the PPE. So I think that that's interesting as well, as we don't really need to do those things, and we unfortunately have thus far shown not to be able to curb the outcomes. And then what credentials should you have? This is, of course, a hot topic, and one of the things specifically discussed at our conference, and I'm curious if it comes out in the new book, is whether or not we should have chiropractors do these or mid-levels. And it was discussed that mid-levels were probably acceptable to do PPEs, but it was probably not acceptable to have chiropractors do them, according to the editors. So we'll see if they actually publish that into the book or not. Okay. So here we've got some comparisons. And so we've got the national form, which is on your right, and the state form for Iowa, which is on the left. And I believe that we'll hopefully be able to get those to you in the future to be able to utilize. But you'll notice there's some differences, changes in the number of questions, changes in the wording of questions. And then here's also the national form, where we have the physical exam portion. It's divided into 2 sections. The top is more of the medical background and examination, and the bottom is more of the orthopedic examination. And then in the center, the clearance form, which mirrors the bottom of the Iowa State form, that we see here in this section, it has those different categories that we talked about, which is basically the clearance, full clearance, no recommendations necessary, partial clearance, follow-up necessary, or no clearance at all, restricted from all activities. And so as we move forward, I was blessed to be part of a meeting yesterday with the Iowa Sports Medicine Association, and we're going to be looking at in 2018 if we update the form based on our committee's recommendations to mirror maybe a little bit closer what's going on with the federal form and make sure that there aren't any gaps between those two. So when we're doing our pre-participation, who thinks they know what actually is required for the athlete to take back to the school? Which one of those pages? Is it the history? Is it the physical exam? Is it all of it? Is it the clearance portion? It's actually just the clearance portion. Okay, so technically speaking, unless the athlete has signed HIPAA, FERPA, all those things where there's the communication between the school, the coach, the trainer, and us, we technically are only supposed to be giving them back the clearance recommendations, which means what? We have to be really specific about what we put in that particular section. Now, I think that this has not been really brought up too much with regards to, a lawsuit of communication, because there are the nice agreements that we have with McFarland and athletic trainers and the physical therapists and all the group that works with our student athletes on a day-to-day basis. But technically speaking, it's recommended that you only give that clearance portion of the form back to the athlete, because the rest of it, if it's going to someone who's non-medical and just getting filed administratively, is not necessarily allowed. However, we can, as a group, have our athletes sign a release form, a HIPAA form, and the school has the FERPA form. And so that's a way to get around that. We talked about potentially the legislative updates in 2018, which would be great. Epic dot phrases, I have one that I use, and I think that's great to create those. It helps you, it guides you through, and if you have an ability to just have formed like yes and no's, you can enter whatever you want with that. I will say that I tend to use the federal form and then actually just input it later. But then I also have portions of the physical exam with epic dot phrases that I can kind of blow in there so that I make sure that that's more complete than the regular form. And so clarification is really key here. And in your note, you really need to clarify what you're telling that athlete, particularly if they're in that moderate risk or the partial clearance zone. And so you're wanting to not only write that down, but also educate the parent, because that's always the worst when they come back to the school and they say, well, Dr. Bancroft said I was fine. And then the form says, well, Dr. Bancroft said I need an EKG, and if I don't get the EKG in the next 2 weeks, then I actually can't participate. And they look at you cross-eyed because you didn't talk to them about that. You just handed them the form that. So make sure you're educating them about what you're actually putting in the form. So some of the examples of things that I put on my form, for instance, is let's say they have elevated blood pressure. I might write out in the moderate section, recheck blood pressure 3 times in the next 2 weeks. The athletic trainer is supposed to call my office with the readings. We're going to hold them from participation if this is not completed. I don't want any heavy lifting until they're fully cleared by a physician. And that allows them to do some things, not heavy lifting, but other things they can do. And then the trainer can work with them and call my office and say, well, the readings were X, Y, and Z. And I can then say to her, no problem, the athlete's fully cleared. I'll send you a note saying that. And then I send her an electronic note, or him, whoever it is, and say that the final clearance is done. Another thing that we put on the form is maybe they've had recent surgery. And so I'm not going to clear an athlete from a recent, we'll say, rod in their 5th metatarsal or ACL surgery. I'm going to say recent surgery must have clearance form from whoever the surgeon is, right? Because I'm not going to clear them from that. But if they get that clearance form on file, then they can safely participate once they're ready. Okay, so this is a copy. Again, we're going to get you guys a copy of this, but it's actually a compilation, and I did this in bare bones a couple months ago, and some of you guys may have looked through this, so you can get back into that. I think it was number 8, bare bones number 8. But it's basically a reference to this large chart for medical clearance that is in the pre-participation manual, and it essentially is a shortened version of about 6 pages of that, and it basically tells you who has to be held, who then can be held until the condition resolves, who's okay to participate, and then who may participate, but we need to make sure that the athletic trainer is aware. And so this is a very large list, but when you're looking at pre-participation, anything can happen, right? So what do I do if someone has one testicle? What do I do if someone has active diarrhea? What do I do if I have fever? And so instead of going through all of this, I've consolidated this, and I've actually used it for mass participation screenings. I've given this to every provider who's been participating, so they have what I call a cheat sheet in order to make sure that they know what to do if some weird, crazy thing comes up, because they do come up. And then also a few more examples of things are on the left side there, where we can see things that I also will put if their vision is not correct, like must have updated vision exam within the next month. And a lot of times I try and decide to myself, is this something that is going to catastrophically cause an issue if I let them do this in the next 2 weeks? Or can I let them do something safely under monitoring from my trainer, but they just need to have it done? So I put a timeline, and I try and make that timeline reasonable for them, but I also make them understand that if they don't follow through with it within this certain timeline, that they cannot participate after that point. So that then gives the onus to them, and they don't have to necessarily do it tomorrow, but they do have to do it, otherwise they're going to be held. So it creates a little bit more ownership on them to be able to get all those things into us. Also, other things is if they have seizure disorders, things like that, we need clearance from the specialist. Maybe they have clearance from cardiology. Maybe I want documentation from an EKG echo that they had previously. And that does need to then potentially go in the file at the school, because otherwise we won't have updated information on them. The nice part about Epic is, of course, we can review all of that internally, but if they're coming in from outside locations or they maybe have just moved to the area, then we need to track those things down. Okay. All right, so the next portion of the lecture, we're going to focus on what I call the gray zones. And this is where potentially we as providers can intervene or maybe change the trajectory of what's going on. And we're going to discuss through some of these harder topics and key topics, specifically the cardiovascular health, orthopedic, medical issues, and some with female athlete. And this actually kind of marches through that PPE form. So this will hit majority of the things that are not the outliers, like the last sheet with the red flags and cheat sheet that I created. And these are things that are probably going to come up on a regular basis if you're doing pre-participation physicals. So the first thing we've got is blood pressure. This is actually the #1 cardiovascular abnormality on PPE. And of interest, AAP actually updated their guidelines in 2017. And so essentially what it's saying is there's 3 readings that are 95th percentile or greater. They kind of subdivided that out, if you look down here, as a goal if they're 13 or older of less than 130/80. Okay, so there's a lot of recommendations to make sure that they didn't take something to raise their blood pressure ahead of time. I've had lots of nice, particularly high school football playing boys who want to come in and drink a Red Bull before they do their physical and wonder why their blood pressure is 160/100. And so then we say, well, that's probably due to some ingestion of a secondary substance. But there's guidelines based on if they already have a family history of high blood pressure and obesity, and then also whether or not they need to have further testing. The biggest thing here is that we do want these people to exercise, right? Because that's the goal. A lot of times their blood pressure is high because they're overweight or they're not very active. So the goal here is not to restrict them, but the goal is to make sure that what they're doing is safe for them. So we do want to restrict specifically weightlifting and any heavy straining until we get to the bottom of this. But we want them as soon as possible to be able to do the exercise that they've set out to do. So there's a lot of things to go through there. I think they've kind of scaled back on the requirements for like renal ultrasounds, echoes, things like that. Some of the lab work is still mostly recommended in the 95th percentile plus category. And Bethesda, which I call it our Bible of sports cardiology, but it has been updated in 2015. That one is similar, but it also has a 99th percentile, but then also 95th plus 5. So you can use either one. I think the AAP being more recent is probably much more accurate right now, and it's kind of consolidated, and so we're not doing too many tests on these kids that just have high blood pressure readings here and there. Bethesda is something we'll talk about in a little bit because it actually has all the guidelines for everything you'd ever see in sports cardiology. It's like 150 pages, and I look at that document a lot. I don't print it out because it'll kill my toner. But I do a lot of searches on it to see, what do you do if you have valve abnormalities, et cetera. Okay. So cardiovascular health, 20% of our PPE is related to this. It's a big deal, right? Because sudden cardiac deaths are absolutely terrible on the sideline, but they do happen. And so this is really important that we get an accurate assessment. One of the things that I think is really important is that the student athlete understands the question and that it comes from an answer of both what they think and their parents think. So when they're filling out their form, you need to make sure that they're with a parent who can help decipher what these weird words mean, okay? And then they can also have the parent input, So they may say, oh, I've never had syncope, I've never passed out, I've never felt dizzy. And then the parent says, well, wait a second, you just told me you were dizzy, last week after you worked out. So input from both sides is really helpful. In adults, whether we even screen or not is really the only thing that we're looking at for cardiovascular health. And so if we look down here, though, the actual incidence of sudden cardiac death, although the news media would make us think that it's a lot higher, it's so much lower than even getting, unfortunately, killed in a motor vehicle accident. So if we compare pediatric sudden cardiac death and a motor vehicle accident, it's way lower. The highest category that we just briefly touched on was African American male basketball players. So their incidence is actually really high. But even them, we've shown that EKGs aren't necessarily going to prevent sudden cardiac death, which is kind of sad. In adult population, our sudden cardiac death rate is a little higher, but again, it is much lower than motor vehicle accidents. So we again are very saddened when we hear about these cases, but they don't occur that frequently compared to normal daily life activities. So we're going to talk through different categories here. We've got different types of things that can occur in the heart. And, so we've got congenital issues that are structural, acquired that are structural, some with a structurally normal heart but essentially have electrical pacing issues. And so what we see here is there's a lot of different causes of sudden cardiac death. And how are we possibly supposed to screen for all these? I mean, commotio cordis is when somebody basically gets hit in the chest and abruptly their heart stops. And that's actually one of the top 6 leading causes of sudden cardiac death. I can't screen for that. Okay, so we do as much as we possibly can, but we really cannot possibly screen every child for everything because we can't prevent things like that. Okay, so a couple cases, right? So this was a case that occurred 6 months into my post-fellowship. I had a 16-year-old male football player. I was actually just calling the trainer to update them on another athlete I had seen on my way home from work. And she's very frantic, and I was like, what's going on? And she's like, well, the other trainer who's on football had a kid collapse. And we're getting EMS, and he's being transported to the hospital. And I was like, whoa, okay, so this is the end of practice. Athletic trainer was there. We activated our emergency action protocol. CPR was going on, AED attached, transfer to the hospital, died 45 minutes later. So the next morning, I come in, I've got several phone calls, emails, things like that, meeting with the hospital's meeting with the press. This, I believe, did make national news because my husband and I watched it on ABC. And now what do we do? The gut reaction, of course, is, well, everybody needs to be screened. And so, then who's going to do the screening? And are they equipped to do the screening? And what are we going to do for the screening? And, everyone minus, myself ignoring what the AHA recommendation is, which is history and physical exam, and screen if you see signs, symptoms, warning signs, things like that, okay? So we went through this whole process. It was very, very difficult on the community. It was very difficult on myself, the cardiology department. They were present. The cardiologist was present when the athlete died. Very devastating. Didn't want to see anybody under the age of 18 in his office. And so now what do we do? Well, we're going to screen all these kids, and we're going to screen them from age 12 up, but where do they go? Well, they're not going to see us because we're going to see kids that are 18 and under. So we're referring out to University of Chicago, we're referring out to Indianapolis, we're referring to Mayo. We had a terrible false positive rate because the people who were screening, particularly with echoes, were overcalling things and not getting the correct views. So this is a very tricky thing. The autopsy in this athlete actually showed ARVC, and ARVC is almost undetectable on screening, although there are some late findings as the disease has progressed that you might be able to find. And Dr. Kovacs, who co-authored Bethesda, happens to be in Indianapolis, and he ended up being this family's physician, and he actually came up to our hospital to do a lecture on sudden cardiac death after that. He's the NFL Combine team doctor, and so I was able to share some patients with him and collaborate with him on making sure we were doing the right thing in the future. So that was very very interesting, I guess, but sad for everything. So then after that, we did this initial push of all these screenings that was prompted again by reaction. And every athlete at the high school and junior high of this community, and then the neighboring community, also had screening EKGs, again, performed by non-medical staff, parents, sent to a cardiologist in Chicago. And then they were read and they were sent home something in the mail. Could I get a copy of that screening for my medical record? No. So we had this huge disconnect. And then case number 2 happened about 3 years later. So we had an 18-year-old. He was a baseball player, right? And he was playing club basketball, right? So, as many of you guys who've worked in the high schools know, there's no way that our athletic trainers can cover every single sport at every single time. But he's playing club basketball. There's people around. We have AEDs all over the school now, okay? He had an EKG screening, and he had no history on his physical exam or his history PPE, because I checked it after the fact. So he tells the coach he needs to go just take a drink of water, and he collapses in the hallway. But, high schoolers don't really think, oh, there's somebody laying in the hallway, sadly. They think, oh, he's just sleeping, right? And so they literally have 10 minutes of video footage from this hallway of people walking around this child. And the AED is about 10 feet away, unlocked, sitting there, ready to be used. And there he is. And so after the fact, 10 minutes later, the coaches and parents realized that, oh, maybe he wasn't actually just sleeping in the hallway like everyone thought. Started CPR, but it was too late. And in this case, the autopsy revealed that they don't know why he died. But again, very confusing, right? Because this kid got screened. He had an EKG. He had pre-participation. Why did he die? And we don't know. Okay, so here we've got our most common cause of sudden cardiac death in the United States, which is hypertrophic obstructive cardiomyopathy. It's a pretty high prevalence, and most of these athletes present with high school or college, and it's about a third of our sudden cardiac death. In other locations like Italy, where there's a large body of literature, they're actually seeing more ARVC, which is a genetic disease, which we're going to talk about next. But again, looking back, we have a study that showed only about 21% reported symptoms 36 months prior to dying. So this is really tricky. Some had pre-participation physical exam findings of a systolic ejection murmur. Most of them do show some EKG findings, but the actual diagnosis is from echo. So you can see here is a echocardiogram, and I won't pretend that I'm a fantastic cardiologist echocardiogram reader, but this shows wall thickening, and the cutoff really for certain is 15 millimeters or greater of wall thickening, but that 13 to 15 range is always that, again, tweener zone of, well, what do we do with you? How do we know? But in general, if they have symptoms and wall thickening, we will re-echo them if they're in that tweener zone, usually at 1 to 2 years, and then follow them out to see if they continue to develop any worsening thickening or outflow obstruction. But as we talked about previously, the USPTF still does not recommend to screen with anything and not even in high-risk people for this. Okay, so ARVC. This incidence is actually a lot less. It's a lot higher in Europe, about 1 in 5,000, 4% of sudden cardiac deaths in the United States. This is bad. Okay, so hypertrophic cardiomyopathy, there can be some surgical procedures that can occur. They probably won't be able to participate still because the heart muscle has to be cut and all these different things. But at least they're probably going to live. In this case, this is really tricky because essentially you're getting this disorganization of the muscle fibers over time, and they fill in with fat. And that then leads to this thinning of the wall and then ballooning over time. And so these epsilon waves that we see down here in EKG are very late, like phase 4, okay, of this disease process. But these guys really cannot be put in any type of physical strenuous activity. There's even question over whether or not their brothers or sisters can be, if they have the anatomic variant, in physical activity because this is so high risk. This is also really hard to catch on echo, and it's very operator dependent, I would say, with regards to whether or not we're going to get a good view, whether or not we're going to hear anything. This is a really tricky one. So last thing is, what's the cost in prevention? Again, this is a huge debate in the community of whether or not we need to screen everybody. So I just kind of did my own little calculation. There's lots of studies and calculations out there. But if we look at, first of all, this list, and majority of sudden deaths are cardiac, okay, so at least we can start with that with regards to sports. Here are the different outlines of things that are the highest hitters, we'll say. So the top 4 causes, and commotio cordis, I believe, is 5th or 6th. Then we kind of look at what are we looking at, okay? So overall, the deaths-related cardiovascular events is about 100 per year, okay? So we probably hear about 50 to 60 of them in the news, right? But it's 100 per year for the millions and millions and millions of kids that participate. So let's say we've got 7.8 million high school kids. So we're actually excluding all the junior high and elementary kids and all those things. And a cost for an EKG with interpretation, we'll say it's like, somewhere between $200, and that's kind of a ballpark. And we're going to screen $200, $400, and we're going to screen these kids. And we need to screen them once every other year, right? Because their bodies change, and we don't know if something's going to show up now or then. And so, our cost is really high, Like, it's in the millions and millions and millions and millions of dollars, $200 to $400 million just for EKGs. And we're looking at 100 deaths. And again, this is not me saying that I'm trying to be unempathetic, because if this is you, or this is your child, or this is somebody you know, this is everything, right? This is 100% you. But what we can't do is react to what we see and try and screen everybody. So when we look at, and then we also look at the second leading cause being anomalous coronaries, we can't even see that on EKG, and it's hard to see on echo. So, you know, where do we go with this? It's a really hard topic. Oh, and then also the false positive rate. So let's say we have a 3% false positive rate, which is pretty low. That's 60,000 false positives to chase down. It's a lot. Okay, so who needs an EKG? Who needs an echo? Should we mass screen? Well, good news. Okay, we have some new EKG guidelines, at least. The international consensus guidelines that are on the next slide we're going to talk about are great, and they were published in 2017, ages 12 to 35. And so we can use these now to be able to at least effectively interpret what we get on EKG. But again, going back to who should we screen, the Bethesda and AMSSM are not really telling us that we should be doing this unless there are symptoms. So it's still, unfortunately, going back to, well, they need to have symptoms, they need to have physical exam findings. And there was no ability to tease all of that out and say we should screen everybody. And so here's a slide that I spent a 2-hour workshop with Dr. Dresner and some of the people working under him learning about. And so this is fantastic that we have this now, and it's basically, 20 plus years of work from him and all of these other people looking at sudden cardiac death. And so the right-hand column here are anything that we consider a normal variant for an athlete. So if you do an EKG and you see any of these things in the green box, you just disregard them. They get totally thrown out. Okay, they are normal athlete, no matter what else you see anywhere else on the EKG. Okay? Second box is the borderline findings. Okay, so what they found is that if you have 2 of these, that you then needed to go into further evaluation. However, if you have 1 and that's all you have, and again, we're throwing out everything in this box, okay, so just 1 of these, then no further evaluation. Lastly is the abnormal. So any one of these, or one of these plus this one, however you want to say it, all of these need to be further evaluated. So we got this new handy dandy ability to screen, and so we need to look at what we're ordering too, though, okay? So are we ordering the right test? Okay, do they need an EKG? Do they need an echo? What are we actually looking for? And the tricky part is when somebody comes in with just symptoms, sometimes we don't really know. Sometimes we think that they need one thing, but maybe they need both. I in sports medicine, again, with having a history of kids in schools I've participated with, not ever seen by myself, but passing away from sudden cardiac death, I tend to be liberal, right? Because I don't really want to miss something and then have a sudden cardiac death. But we need to make sure that we're ordering the right tests. And many of these symptoms could be either the EKG or the echo, but they might also be both. So consider what you're ordering if you are going to screen because of symptoms or physical exam findings. So here we go. This is our new cardio machine. So we have one of these at Iowa State. And I, after learning about all of the international consensus and how good this cardio machine is, I think we need to look into getting one of these either in cardiology, pediatrics, etc. So this was released in 2017 and has pre-programmed international consensus guidelines for EKGs in it. And when I'm talking to the people who did the lecture for me, number 1, the false positive rate is 3%, which is amazingly low. Number 2, they are finding that it is more accurate than their cardiologists, which makes cardiologists sad, right? But in reality, it's good. Because if we can have a tool that objectively identifies this for us and puts in big red letters normal or big red letters, epsilon wave concerning for ARVC, that's great. So this is a fantastic tool. It is not that expensive. I'm told it's actually cheaper than a regular EKG machine. And so I highly, highly, highly recommend that you try and utilize the criteria for international consensus and or the Cardia machine, because it's just going to do it for you. So this is great technology, and it's really, really, really good for screening. Okay, so in conclusion with cardiovascular, just take this section here seriously. Remember that diseases have to start somewhere. So essentially, you don't know when they're going to start. I don't always say that an athlete who has had screening and it was negative is always going to be negative. So sometimes you got to repeat your screening. Err on more testing. Again, if you're nervous about them, follow your gut, chase it down, make sure it's okay. And refer to your friendly sports cardiologist to help out if need be. Okay, next section is orthopedic issues. This is going to be brief. This is really our second most popular topic, and we mostly don't see acute injuries. We more see chronic issues with our orthopedic screening and pre-participation. And so we really need to get to the bottom of what happened and what's occurred. So we need to know who's seen this athlete. How many visits have they had? What type of imaging studies have they had? Are they wearing bracing? Are they in pain because of what they're doing? And this can take a little bit more evaluation. Specific categories that can be ongoing down here are Down syndrome and JRA kids, but particularly hypermobility. In talking with Heidi Collins, I used to be near her in Indiana, and she's the director of the foundation for Ehlers-Danlos. She'll tell you that up to 10 to 15% of athletes have hypermobility, and that's in some ways good for their sport, but can down the road be difficult with their sport. And so looking at all these things and making sure you're documenting them and able to refer them to the appropriate specialists. On the right here, we've got actually what the PPE shows as the appropriate physical exam screening, which I think is fine, because in my high schoolers, I worry more about their cardiovascular or major events, and to be truthful, a little less than their orthopedic, unless they have a complaint. Okay, so if they're not complaining of anything, great, do the basic screening, done. But if they do have issues or they've had appointments, you need to know what they've had done. And so a lot of times, even just getting an x-ray on something, we've had a lot of outliers, I guess we'll say, and kids who just don't seem like they're getting a lot better, or maybe they're getting worse, and I've gotten an x-ray and I'm like, whoa, there's an old fracture right there, or whoa, so getting an x-ray is never a big problem. I would always do it. Specifically with orthopedic issues, you want to make sure you're doing a more thorough joint exam of that area. So if you're doing the basic screen and they either have pain or they have an ongoing problem, do your full, complete orthopedic exam in that area. I did have a fracture come in, a cuboid fracture, from an outside clinic this year, and the kid just came in with pain and swelling, and the primary care provider said, I'm just not sure this is right, and he didn't want to admit anything, and nothing showed up on x-ray, but then there it was. So it can come in on a I'm not going to tell you I had an injury, but I want to get through my PPE basis. So okay, so asthma allergies. With this section, we need to make sure we're screening for severity, and have they had a PFT or allergy testing, and what medications are they on. So I had a high school quarterback where I was at. He came in actually audibly wheezing into my office, and he's like, this is how I normally am. I'm always like this. So we talked through what he's on, and he's really only been on albuterol as needed. He's not on a long-term beta agonist. And so we essentially put him on that, got him a PFT, that type of thing. At our location, I've worked with allergy and asthma. Lisa's the respiratory tech, and she's fantastic. We actually can do exertional PFTs now. So PFT, I think it's 13 and 18. We actually order those together, and you can put sports medicine protocol. And what Lisa will do is she will do the PFT, take the kid downstairs, run him on the treadmill and physical therapy, and then she brings him back up and redoes it to be able to confirm or deny whether or not an exertional component is there. So that's been helpful to us. Also with vocal cord dysfunction, they can be seen by ENT or in the therapy office to try and work with speech sometimes. And is there actually a cardiac cause for their dyspnea? We need to make sure of that. In Indiana, we actually are allowed to prescribe Ventolin and epinephrine to the schools, but please make sure that your athlete has multiple of those at different locations, because they need to make sure that they're able to deal with their exertional dyspnea or their allergy at any location. We don't really have the ability to do that yet, but hopefully they'll consider passing something like that in the future. Okay, so head injuries. This is, of course, a hot topic. On the right, we have a box here where we have contact, limited, and non-contact sports. And so you should categorize with your athlete what sport are they in and what type of contact may they have. So I'm going to talk a little bit about concussions and what some of the things that are coming through with our testing and things. So we really don't know when true recovery is from a neuropsychologic point of view, and so there's a lot of studies going on with gait and balance. Also, Dr. Letty is doing a study. He came up with the Buffalo concussion treadmill test, and so he found that there was an abnormal response to heart rate, and it actually was decreased at the beginning of exercise. The exertion perception of the athlete as they went through this treadmill test was increased, although their heart rate response was the same. So what this tells us is there's a change in the parasympathetic and sympathetic overdrive that occurs with concussion. And so he's using that to try and tell his athletes when they're safe to go back, and has published many studies on this. And in addition, we do now that exercise is actually good. So we are starting with the schools we're partnering with doing low-level exercise even on day 2 to try and get those athletes back more quickly at a 50 to 60% max heart rate. And I do encourage you guys to use that with your student athletes, because we used to be like everybody needs to lay in a quiet, dark room. But the reality is we know that that's not healthy, and it's probably not going to help the brain recover to where it needs to be. So making sure that you're getting those athletes moving at a low-level heart rate. I usually tell them don't have a heart rate that exceeds 110 or 120, because that's basically 50 to 60% of their max heart rate. And they tend to do pretty well with that. And hopefully they can be overseen by somebody either at their house or with an athletic trainer to make sure they're doing okay. But stationary biking, jogging, all that stuff, get them going, let them do it as long as their symptoms don't increase. Okay, so is there a cumulative effect of concussion? This is also a huge question. Probably. But there's also likely a genetic component that goes into this. And so there's a big research gap here, because we've got this terrible looking brain here on the right with advanced CTE, and then we have the normal brain on the left. And so there's a ton of research going on how do we predict what's going to happen between that 5-year-old playing tackle football if he gets to the NFL and he's 35. And how do we know if they're going to get CTE? So CTE is everywhere, but we're really not to where we need to be yet to say that this kid's going to get it and this kid's not going to get it. So stay tuned on that. Blood biomarkers. This is actually going to be huge, and it's going to be very soon. So we are really close to having at least a acute biomarker, not a sideline biomarker. The S100B has been approved over in Europe as a precursor to not do a CT scan if it is negative in head injury. And so fast forward, we've got all these kids, and Dr. Lavarian came and spoke. He's an ER doc up in Minnesota, and he's like, we have protocols for this, but basically about only 10% actually follow the protocol. We just do what we want because we don't want to get sued if there is a brain bleed, so we CT scan everybody. But if we had at least a blood test, maybe we wouldn't have to radiate all these kids. So this is great. that we can do potentially a blood test and get that done instead of doing a CT. But what we really want is a study that shows us a blood test in the first hour, and we don't have it yet. And that's really the goal, and what we're doing a lot more research on is to get a sideline test just like a blood glucose stick. And so, again, stay tuned on that because we would like to get that. Then we also want to get a blood test for clearance. Okay, so tau is maybe going to come out as a blood test we can use for clearance back. But there's a lot of things that we're studying and haven't really come to fruition, but it would be great to have a biomarker to say, yes, you're ready to come back. Imaging, regular CT, not helpful. Rules out of brain bleed, that's all we got. MRIs, probably not helpful. Functional MRIs, yes, but who's got a functional MRI scan? Most people don't. So there are some studies, the CARE-ARC protocol with NCA is doing functional MRI scans on concussed athletes and follow-up and serial scans to see if we can track things, predict things, that type of thing. But we don't have a functional MRI scan readily available. Objective physical exam findings, again, they're studying things like gait at Boston Children. Meehan's done a lot of studies on this. Vision testing. I think vision testing is great, and this somewhat segues a little bit into our C3 testing, which we're going to talk about briefly. That is awesome to be able to have an objective physical exam finding where we can actually look into the kid's eye, and they're 10 years old, and they don't have to tell us they have a particular symptom. We can just view their pupil and say, nope, you're not ready to go back. And so that's on the horizon with the testing. We are using C3, and that does have some visual ocular testing that we can utilize. So our baseline testing program that we're rolling out and working with Ames High School, Gilbert High School, and Ellsworth Community College, we're able to test anyone also at clubs and other locations through our office as well. That includes neurocognitive testing, objective physical exam data with balance and visual acuity, and then we also have reporting software capabilities where the trainer on the sideline can report to us or the parent or a nurse, and we can get that incident report to us in the office. We can make sure that we're monitoring them. We can communicate with our physical therapists that are doing some of the follow-up treatment on them. And the protocol is actually the last bare bones article, if you guys are more interested in that as well. So that's the logo there. Okay, so heat illness is something that we want to make sure we're talking with our athletes about. They need to make sure that they are taking in about 17 to 20 ounces of water 2 to 3 hours prior, 8 ounces 20 to 30 minutes before exercise, and 7 to 10 ounces every 10 to 20 minutes and then after. Making sure their weight loss isn't too much when they're exercising. So greater than 5% weight loss is very bad. We really want them in about that 1% category of weight loss, or not even weight loss, to make sure they're not dehydrated. But talking with your athlete to make sure they haven't had symptoms of dehydration or episodes, and how do they prevent that. And essentially it's take a water bottle, drink some electrolytes if needed, and keep up with it if you're going to have a hot day. And I think our coaches have been better at letting people take frequent breaks or do the things that they need to do to keep their body healthy. But if they're not, then we need to re-educate and maybe work with the trainer to get that updated. Okay, last is female athletes. So female athletes are tricky and overtraining syndromes. And so when we're screening them in PPE, we need to make sure that we're looking at their weight, where they're at, their diet, what are their goals, and why are they maybe choosing a particular diet, maybe they're restricting, doing all those things, and is it realistic? In general, in the menstrual cycle area, they need 10 or more periods per year, and I usually categorize this after 2 years. So I give them a little leeway, because not every girl's period's going to be normal right away. So I tell them if it's after 2 years, then it's probably a bigger deal. Also looking at maternal history of what mom had is helpful. And then stress fractures. So this is a chart of high-risk stress fractures, low-risk stress fractures. And so this actually is important to know when we categorize the risk of the student athlete. And so a couple of cases here. I had twin college athletes when I was doing my fellowship, and interestingly, they came into different bays. I was screening one, and another person was screening another. They were coming into the cross-country team. Both of them had a BMI of about 16, and you could literally see every bone on their body. And what was so interesting to me was, I immediately was like, whoa, these people have an eating disorder. I told, there's just no way they don't. And me and the other providers kind of came out at the same time, and we just looked at each other like, this is a train wreck. So they were completely codependent on each other and eating, and had no concept of that anything was wrong at the time that they were brought in. So this was a tricky screening case for us. And then I had an athlete, this was actually last year, referred into me from an outside provider for evaluation. He was totally had shin splints, pain was worsening, history of previous stress fracture, maybe this is one. BMI was 16.5. And so what's interesting is this child had been going through, he was an upper level of high school age, and had never been told or talked about per the parent and himself. They looked at me like I had horns coming out of my head, that there was anything wrong, or that they had never ever had an issue with their nutrition or stress fractures or anything else. So we did do standard protocol, and he had a grade 3 stress fracture. But I was trying to explain to him through this whole process, his BMI puts him at extremely high risk. He really shouldn't be running, and on and on. But of course, with me being the outside provider and his primary care who screened him, never talking to him about any of this, he essentially then decided that he would go find another opinion, and Dr. Bancroft's opinion was totally wrong, and didn't ever go to nutrition, and is probably still low body weight, and why is he doing this to his body? I don't know. So that was difficult. Okay, so ACSM gives us clear guidelines on female athletes, and it talks about what we should ask them. And so these are the pre-screening questions that we have for all of our female athletes. And what this kind of boils down to is the ACSM came up with guidelines in 2014 and through the Female Athlete Triad Coalition, and the grading system basically tells us whether or not they're low, moderate, or high risk again. So we're kind of subsetting out, just like we talked about the initial clearance, but now this is a sub-clearance within female athletes. And what we look at is BMI, so greater than 18 is normal, less than 17.5 is high risk, delayed period, so if they get it before the age of 15 versus greater than 8 or greater than 16, if they're not having appropriate numbers of periods that we talked about, Z-score, that can be tricky because not many of these people usually have bone densities, and then stress fracture risk with the high risk versus low risk stress fractures. And so it boils down to 3 categories: the low energy availability, menstrual irregularity, and low bone mineral density. And usually the bone mineral density is the last one to show up. And so we need to be careful, because what we know is that we can screen for this low energy availability and the menstrual regularity, but the bone mineral density is later on, and we can't really usually screen for that in PPE, but we can ask them specific questions and look at their BMIs to make sure that they're safe. One study even found that less than 19 increased recovery time for stress fractures 4 weeks. So it is kind of a big topic there. Okay, this is kind of the general workup that we look at for female athletes if we need to. And some statistics find that in what we call thin body type activities, dance, cheer, running, things where they need to be lean, the incidence of eating disorder is upwards of 20 to 30%, and disordered eating is up to 2/3. So there's a lot of high-risk kids that are in those sports that we need to screen very well. But here we have kind of the initial workup based on, and this is really based on what you're seeing with them. It's not that everybody has to have all of these, unless I would say if they're adamantly in an eating disorder, then we generally do majority of these. But if they're not, it's up to you to decide what's best for them to do. Okay, so PPE is an important time to catch our red flags in patients who need who should not participate or need workup. I would recommend not doing a sick visit also as your PPE. If they're there for a sick visit, please just have them come back. If it's a well exam, then you might be able to bundle that in. It does cheat your athlete. Know your form and be familiar with the questions. And don't be afraid to ask more questions or think that there might be something wrong in someone even if you've known them for their whole lives, because at some point they may have a disease that is not good for their participation in sport. We can't really prevent sudden cardiac death, but hopefully we gave you some resources that you can turn to if you do have a bigger issue on your screening. You can look at those guidelines and follow through with that athlete. Okay, thanks. There's my kids with Psy, their favorite thing. Any questions? I know we went kind of long, but.